factors on age-related macular degeneration, a very, very, very hot topic. Thank you, Stefan, for doing this, knowing your expertise in this field and leadership.
Yeah, thank you very much, Annette. Thank you very much, Frank, for the opportunity to join this exciting symposium. And also best regards from Monica, who was originally assigned to give this talk. 52 genetic variants in 34 loci have been associated with clinical AMD manifestation, and the two most common genetic contributors are variants associated with CFH, CFHR5 on chromosome 1, and ARMS2, HTRA1 on chromosome 10. Only minor genetic associations with less penetrance have been found in other variants. Those are likely more modulators in the presence of CFH and ARMS2. There's one exception, and these are so-called rare variants. So these subjects have a clinical AMD manifestation, but do not carry any risk at CFH, ARMS2, or C3. And this occurs in about 5% of subjects in large AMD cohorts. Looking at the AMD landscape and asking the questions, are all genes equal in AMD? It's kind of interesting to note that even we have been known about this genetic knowledge for about 15 years, that it does not play a role or only a minor role in clinical AMD research or even management. Trying to better understand the underlying biology, different molecular pathways have been associated. The biggest one, or the most prominent one, the complement systems, and others include lipid metabolism and transport, extracellular matrix maintenance and remodeling, angiogenesis, cell survival, and oxidative stress. When we also ask this question in more detail, we have to acknowledge that the cause or the contributing factors of manifestation may be different from those causing further disease evolution. So, for example, the incidence of GA may be driven by other genetic factors as compared to the expansion of existing lesions. High-resolution imaging shows, for example, that different pathways and different precursor lesions may lead to manifest atrophy manifestation. For example, if you think about drusen evolving atrophy as compared to developing of drusen at a site with extensive reticular pseudodrusen prior to that. Or further development of macular neovascularization subtypes is distinguished or might be distinctive from the underlying mechanism of degeneration. These thoughts have been discussed in detail by Tian Keenan in this work here called A Tale of Two Stages. The IRIS Consortium has done pioneering work on the topic, and doing a cluster analysis, they have identified three partially distinctive GA subtypes. Number one, there was a high frequency of soft drusen and central GA involvement in association with a higher complement-based genetic risk score. Number two, the low frequency of soft drusen and reticular pseudodrusen was associated with a low AMD genetic risk score. And another extreme, number three, high frequency of reticular pseudodrusen and lower frequency of central GA involvement was associated with a higher ARMS2 and extracellular matrix genetic risk score. So this may be regarded as an oversimplification, and indeed the ARIDS2 group was not able to replicate these findings in their data. However, in 2023, we also have to think about that ARIDS2 and many other AMD cohorts have enrolled participants many, many years ago, while our understanding of AMD manifestations and phenotypes is constantly evolving, thanks to high-resolution multimodal retinal imaging and also discoveries in genetics. While the distinctions to late-onset Stargardt disease and central iriodystrophy as mimicking diseases of geographic atrophy secondary to AMD should be clear in today's AMD world, there are other manifestations which are not as clear. A good example is the trickling type. When we looked many years back at different progression rates in geographic atrophy, we were thrilled that this trickling pattern is associated with a much more rapid progression, on average about 3.5 square millimeters a year, as compared to 1.5 in the overall population. This was in the FAM study and later replicated in the GAP study. Trickling is associated with a lobular pattern of atrophy, grayish appearance and autofluorescence, extensive reticular pseudodrusen, and also a common splitting of the RPE and Brooks membrane. But now looking more into risk factors. When we looked at general risk factors, there was an amazingly increased risk of cardiovascular disease and trickling, with myocardial infarction and history of hypertensive crisis. And finally, looking at genetics, the tricklings are shown here in the middle on the graph. You can appreciate that the genetic risk score for AMD is higher than in the general population. This is on the left, but it's lower as compared to the normal AMD population as shown on the right. In Utah, we have access to a large cohort of over 6,000 subjects with a follow-up over 13 years now. And the approach here is different. So we don't look at genetic risk scores. We first consider also protective alleles in CFH, CFHR. And we rather, instead of calculating a general genetic risk score, we identify diplotypes with different combinations of the two most common genetic risk loci. So first and second, these are subjects who are homozygous for risk variants at chromosome 1, while they carry no risk at chromosome 10. Or these are subjects who are homozygous, so two risk alleles at chromosome 10, while they have no risk at chromosome 1. And third, we can look at subjects which are double risks, which carry double risk, so they're homozygous at both risk variants, both 1 and 10. And here we can see an association with a conversion into late-stage AMD. Subjects who are homozygous at chromosome 1, at CFH, they have the lowest risk of conversion, followed by those homozygous at chromosome 10, and the highest risk is present for subjects who are double homozygous. And these differences have a risk factor of conversion of up to 3.3. And this is beyond any structural changes, also correlated with an increased risk of visual loss. Diving deeper into the subject, we did a refined association of genetic risk with morphological risk factors. So going back to the CAM classification of I-RORA and C-RORA. So the two extremes in this table, I know it's very small, but I briefly would like to mention, if you just have medium-sized drusen and chromosome 1 risk, you have basically no risk of conversion within the observational period. But the other extreme, on the bottom right, if you have I-RORA and have double risk, your median time of survival to late AMD is 0.9 years. Looking at the initial manifestation of macular neovascularization, we could show that type 1 MNV is significantly more common in chromosome 1 risk as compared to chromosome 10 risk, while the later has a higher risk of type 3 risk. And this is also reflected by the age at first manifestation. If you have higher genetic risk, you are much younger at the time of conversion and much older at chromosome 1 risk. And these differences could not be found if you look just at the C and V subtypes. Similar applies for the association between genetic group and first presentation of C-RORA. Here again, higher risk is associated with younger age of first presentation of atrophy. And this could also be shown with a different approach on different diplotypes of AMD. Very recently, the AREDS group has also approached this strategy looking at different diplotypes. And in this table, if you have no risk alleles at ARMS 2, your estimated square root progression of atrophy is lower as compared to having one risk allele. And if you have both risk alleles, you progress much faster. And the data shows that these effects are most pronounced in small geographic atrophy lesions, while there are no significant effects in larger lesions and multifocal geographic atrophy. So looking at a disease progression model, the hypothesis is that with increasing AMD progression, more unspecific degenerative mechanisms play a role, like circularity or focality of the lesion, while early in the disease course, the genetic risk factors or environmental risk factors or age play a more relevant role. So in summary, genetic impact appears more relevant for the initial manifestation and in the early course of the disease as compared to later stages. A higher genetic risk is associated with earlier disease onset of late-stage AMD, and early data suggests relevant differences in AMD manifestation between chromosome 1 and chromosome 10 risk. Thank you very much, and I'm happy to take any questions.
Thank you for this excellent talk, and if from the audience you want to take questions, there are microphones standing up. I was wondering, so this is intriguing, and you mentioned the complement system is around for some time, also the chromosome 10 risk polymorphism. Now we've seen for the first time in many presentations here at this EURETINA meeting on anti-complement therapy. What's in the pipeline for chromosome 10?
Yeah, so this is, I think we're here at the very early stages, so it's quite not clear if ARMS2 has also an impact on the complement system. So we don't know this for sure. So there's other data suggesting that levels of complement in the anterior chamber are higher in ARMS2 patients. So we don't know this for now.
Andrew Lottery.
Thanks very much, Stefan. I just wonder if the genetics having more of a role at initiation rather than progression, does that mean it's less likely that anti-complement therapies are going to work to treat progression of GA? We've seen several GA treatments fail recently, so what's your thoughts? Should we be doing anti-complement therapies for progression?
Yeah, this is the logical next thought about it, but I think we need more data to answer this question, yeah.
Mm-hmm.
Do you think that these findings of yours can be important for anti-complement therapy in terms of choosing the right patients for the treatment, which might give us better results?
Yes, definitely. But also we can also look in our existing patients or in the existing trials, because as you probably many of you have seen, that the discussion is at the moment not only the expansion of atrophic lesions, but also to look at treatment effects outside atrophy. So this is presumably an earlier stage of the disease, and maybe we see here more pronounced effects of complement inhibition.
But do you foresee that maybe you could choose the patient according to their genetic variants, if they're suitable or not suitable for a certain anti-complement treatment?
I think this is a dream for the future. You have to acknowledge that these are a very large number of patients, so we can only see these effects when we really dig deep and select patients, what I showed. So if you have a study with 1,000 patients or so, it's not enough and you just recruit AMD patients out of your clinic, you will probably not able to see any effect.
There's one final question from the colleague.
Hi, thank you very much for your presentation. I wanted to ask, at the beginning you mentioned from the 2016 paper we have 52 loci, and now even more loci have been discovered in recent years with even larger GWAS performed with AMD. How do you envision the use of so many loci going forward? You presented only 2 today, but yeah, as you mentioned, there are many others. How do you envision for the future the usage of so much genetic information for your practice in clinic?
Yeah, again, so this is all research. This has no implications on clinical management right now. So it's an attempt to better understand the underlying genetics, but you cannot use this data in your clinical management right now. So these pure genetic groups, they are less than 20 or 15% of an overall AMD cohort.
Thank you.
Thank you very much, Stefan. That was amazing.
And thanks for allowing me to present our data on biomarkers for prediction of exudation in non-exudative AMD. And those are my disclosure. And this is the paper that I will try to summarize in a few minutes. This is a big paper on important biomarkers in different types of MNVs, and actually those that may be non-exudative as they were reported so far. That is type 1 MNV and type 3 MNV. So let's start with type 1 MNV, and I will start with a case. This is a patient of mine that presented the first time with some mottling of the RPE in the sense of a double, triple layer sign over here. So then we performed OCT angiography, and OCT angiography, as suggested by structural CT, demonstrated the presence of a CNV that is non-exudative. So we decided to follow up this patient, and 3 months later, the CNV was still non-exudative, but with this important, huge growth, both in thickness and in size. And also we were noticing that there's a highly population of capillaries inside the MNV. So again, we didn't treat this patient, and a month later, so at 4 months from first diagnosis, the patient presented with a further growth of the CNV, along with some initial exudation. So this is clearly something that is strongly stimulated by VEGF, is a kind of angiogenesis that is what we in general see when a CNV is developing a different condition, particularly with in age-related macular degeneration. So let's move to a second case of mine. This is a patient with still this double, triple layer sign. And at the time when I first saw this patient, we had no OCT angiography. So we performed ICG, and ICG confirmed the presence of a CNV here, late plaque. So we decided not to treat this patient, and this patient came back several times, but this is the picture at 1 year, still non-exudative. 2 years, at that time we had OCT angiography, and you can see that on OCT angiography, the size and the shape of the CNV is more or less the same as 2 years before, if we look at the ICG and try to compare ICG with OCT angiography. And then 3 years, and 4 years, and 5 years, and 6 years, the size of the CNV is still the same. I can tell you that this patient now has more than 10 years follow-up still without exudation. So this is clearly not angiogenesis stimulated by VEGF, but rather a kind of arteriogenesis. This highlights that there could be two types of non-exudative MNV. One that is probably what reported Gus, an initial step in the development of type 1 that will quite shortly develop exudation, and one that is less stimulated by VEGF and that is less prone to develop exudation. So it's important to make differential diagnosis between these two because the rhythm of follow-up should be different, and also the treatment approach should be different. And the growth in size and thickness and also the density of capillaries and the CNV may be a very good biomarker. Then we have type 3 MNV, and type 3 MNV may also be detected before exudation. Let me show you this case of mine. So we have a patient with a type 3 MNV at this exudative stage. This is with the typical characteristic that we know for type 3 MNV. This patient was seen a few months before, and a few months before, at the site of development of exudation, was characterized by presence of round hyperreflectivity that on structural CT may be diagnosed as just pigment, but indeed when you perform OCT angiography, you can nicely see that there is flow inside this pigment. So this is not just pigment, and by combining non-invasive imaging that is structural and OCT angiography, you can make early diagnosis of type 3 without exudation. And this is what we recently reported as nascent type 3. So you can detect early type 3 MNV and follow their progression towards the RPE, this downstream, over time, still without exudation. And indeed, now we know that to get exudation type 3 MNV, really need to get contact with the RPE and the sub-RPE space. So this makes allows you to make early diagnosis of type 3, that is non-exudated type T, and also detecting the right time for starting a treatment. Based on this finding, we wanted to look at fellow eyes of patients with exudative type 3, and looking at these fellow eyes, we realized that in many cases it is possible to make early diagnosis of non-exudative type 3. And when we follow this non-exudative type 3, it takes around 9 months to develop exudation. So you know that you can detect early and then follow it strictly during this critic first 9 months. Another important point is that type 3 develop in the context of GA, so this is another biomarker for you to look for early type 3, even in absence of exudation. And besides GA, so large areas of atrophy, type 3 may develop also in the context of what was around 10 years ago described as nascent GA. So you can have a combination of nascent GA and nascent type 3, and this was already at that time highlighted in this letter by myself. Let me show you this case. So this is a patient at the stage of drusen. You can follow patients with drusen over time, and at a certain point they may develop a nascent GA. This is the time here you can recognize all the characteristics of nascent GA. So this is a critical point for development of atrophy or type 3 neovascularization. And by applying a multimodal approach, imaging approach, so you can detect early type 3 neovascularization at the site of nascent GA in absence of exudation. Follow this like we do for nascent type 3, and also detecting the contact with the RPE with the very initial exudation. And this is the critical point for treating patients like this, because otherwise they will develop exudation, as we know, for type 3 neovascularization. So we also looked at this and recently published a study for the risk of development of type 3 MNV at the site of nascent GA. And as for the fellow eye study, we realized that from the development of nascent GA to the development of exudative type 3, it takes again 9 months. So 9 months is the critical time for development of exudation. So in conclusion, we have important biomarkers by applying a multimodal imaging approach, and particularly structural OCT and OCT angiography. And this may help you to make differentiation between high risk and low risk for exudation neovascularization, and also to detect early the time of conversion from non-exudative to exudative and starting treatment early. Thank you very much for the attention.
Great talk, Giuseppe, fantastic. Just towards the nomenclature, at the beginning of your talk you mentioned double layer sign. We know the zero sign refers to the same phenomenon, but you also said triple layer sign. What should we use?
Yeah. This is you know what? This is a study that we started a very long time ago, largely before the description of the double layer sign by Phil Rosenfeld, but we never published it. And then the paper now is submitted. Finally. And what I call the triple layer sign is this third, between the RPE and the Bruch's membrane, that are the two lines of the double layer sign. There's another line, hyperreflective line, and this is the third layer, so the triple layer means this. The problem with this is that it's, this is very sensitive for a non-exudative type 1. The problem is that it's not that specific because basolaminar deposits as mimicking the presence of MNV there. So the triple ASI is not specific, is much more sensitive than the double ASI, but still not that specific because of the presence of basolaminar deposits. I hope that the paper will be published soon.
I'm sure it will. So you described type 1, type 3. We're expecting your next paper on non-exudative type 2 CNV. MNV.
Wow. We looked for that. We looked for that, and actually there's not.
Yeah. Not yet observed.
No, not
Annette?
yet. No.
No, I'm just just one last comment. So can you tell us, how do you follow these patients with the types that you mentioned? Is there a difference between the way you describe them and the follow-up, and then we'll need to continue?
Yeah, type 1, well, when we follow strictly patients with type 1 for the first 6 months, strictly means every maximum of a couple of months. And if we see this growth, like in the first case that showed, then we start treatment soon. Yeah. For what regards type 3 MNV, now we know that they will develop, almost all of them, probably all of them will develop exudation in a very short time period. And in that case, when we see that is very close to the RPE, then we can start treatment. Okay. Yeah. Not too early, because we have the risk of enlargement of GA that they already have, or atrophy that they already have, virtually all of them, but quite soon.
Excellent. Thank you so much, Giuseppe, once again. And next, it's a great pleasure to call Chemi.
We're now starting to talk about therapies for geographic atrophy, and therefore the interest to understand GA in the various phenotypes and ethnic group has really exponentially increased. These are my disclosures, and I'd like to particularly thank, of course, my funding source, but also all the co-authors on this paper, which I will mention today. So we know that from epidemiological data that the prevalence of GA is much lower in Asians, and even amongst Asians there are different heterogeneity, particularly within the East Asians. This has been described to be very low, and honestly, for decades we haven't really looked at this population in clinic very well. So now, with therapy being possible, these are the common questions we suddenly get asked very frequently. Number one, do Asians have GA? Number two, what does Asian GA look like? And number three, do Asian GA progress differently? And therefore, would they respond to the treatment like in the trials? So first of all, these are some of the examples from my clinic. Do Asians have GA? Definitely. Yes, there is this population, and I would welcome therapy for these patients, particularly if there are clues in the background or the other eye, such as type 3 neovascularization in the other eye. They behave quite similarly to what we know from the Western population. Similarly, this patient with quite a heavy drusen load, these are quite typical looking geographic atrophy. And would we welcome treatment? I would say if I was this patient, yes, okay. You can see that patch of juxtafoveal GA is just about one line scan of the fovea. And looking back and having this historical data is really important to understand that this is quite a fast-growing patch of geographic atrophy. And looking at his other eye, he also has some of the typical drusen kind of background. So with that in mind, we want a more coordinated approach, and so the Asia Pacific Ocular Imaging Society came together, and you can see the co-authors here. We wanted to perform a comparative study to understand the characteristics of geographic atrophy phenotype, progression rate, and to evaluate difference between Asians and non-Asians. This was in the format of a multi-center retrospective comparative case series. Inclusion-exclusion criteria here, I wouldn't spend a lot of time, except that we wanted to focus on AMD-related GA. So we wanted to mandate that there has to be drusen, at least in one of the two eyes, or in the other eye there has to be neovascular AMD, and we want to exclude the non-AMD-related kind of atrophy, which may blur the picture. Images were collected from the various centers. Each center graded their own images, but we tried to standardize by harmonizing sessions and having a standardized grading protocol. And reference images were provided as well. The characteristics of interest are listed there, and I'll go through the results. So just first of all, there is a lot of heterogeneity. These are some of the examples that were collected during this exercise. In total, we included 144 eyes, quite good proportion between Asians, which came from Singapore and Thailand, and non-Asians. Unfortunately, many, all from America, and we look forward to collaborating with our European collaborators soon. So you can see that age and gender were similar. What was clearly notable is that there were fewer bilateral GA cases amongst the Asians. Asian eyes also were kind of as expected, associated with a thicker choroid and fewer soft drusen. This reflects the catchment population. These are patients from our clinic, and so it may be a little bit colored as to how generalizable these data can be. Many of these patients from the Asian cohort particularly were coming in for injection for the other eye. And what was a bit strange was that we happened to find quite a low prevalence of RPD in both the Asian and non-Asian in this small study. But coming to the results, first of all, how about the phenotype? Definitely there are differences. Asian GAs were significantly smaller. There were fewer multifocal lesions, and the associations have been mentioned. These are a few more cases, a lot of drusen, but still the GA patches are not that big. Another case here. And what about progression? Again, clearly there are differences. The growth rate was significantly lower in the Asian population compared to non-Asian, with the average mean being 0.7 millimeters square per year in the Asians and 1.9 in the non-Asian. But you can see there is a spread from the bar chart as well. And when we converted that to square root transformed, again, you can see the difference there. And we further wanted to look at some subpopulations of special interest, and these are those restricted to having presence of drusen, those who met the Darby and Oak study criteria, and those with relatively larger baseline lesion area. And you can see that there is an increase amongst the Asian in terms of growth rates when we add these criteria. But between the two groups, there was still quite a lot of difference, but the difference tended to be smaller when we're coming to the larger lesions. What about risk factors? Ethnicity was by far the factor that has the biggest effect size to determine the growth rate. And after that, when we stratify those according to ethnicity, you'll find that amongst Asians, it was the baseline lesion area number of foci that was important, whereas in the non-Asians, it was the FAF pattern. So the question then coming back, is it ethnicity or is it size? I've already told you it's really ethnicity that has the biggest impact in terms of effect size. But if we then look further more granularly into the size, and you can see the subgroup according to the size, you can see that it's really amongst the Asians, those eyes with very small baseline lesions, which appear to behave differently. So moving forward to future trials and therapies, maybe we particularly don't want to include this kind of patients. So take-home message from this study was that there are indeed differences in phenotypes, in growth rate, but we did identify certain subgroups to include or not to include in future. And how does that compare with other cohorts? We have limited data so far, but for example, from a Japanese cohort, this was not that dissimilar to what we have found. These are the characteristics of the eyes included. Baseline area was similar to ours, was about 3 millimeters square, and the growth rate was similar to ours as well. We had 0.7, and this is 1 in this cohort. And you can see here they did various subgroup population, but overall, this is the square root transformed rate. It was averaging about 0.2, which is again very similar. Certain subgroups we can see with relatively higher growth rate were those with reticular drusen with bilateral GA. So there are some factors. How about other population? Korean cohort, a lot of heterogeneity. You can see big difference in terms of baseline lesion area. The baseline area in this cohort was huge, and the growth rate described was 1.14, slightly higher and higher now compared to previously mentioned studies. But here, very interesting, if they change according to FAF pattern, as we've heard from Stefan's lecture, they found a huge difference, 10 times difference between those with diffuse versus those with no pattern. And again, another study looking at the zones of involvement, which also confirms that those lesions outside towards the zone 6, away from the fovea, have a faster growth rate. But again, just to highlight the very large baseline area. And finally, comparing with, we've mentioned to worry about the non-AMD GA. Is this GA? We know this eye in particular is not, because this eye had a neurosensory detachment, was actually coming in for CSC. But when we see this kind of other eyes, very localized patch, relatively thick choroid, no drusen, amongst the Asian population in particular, we worry whether they are actually not geographic atrophy at all. This is another case, and historical data is really important. We look back, this we now would call a pachyvitelliform maculopathy, but if you were just to see this patient for the first time in 2022, we'll have a hard time to differentiate that. So with that, I'd like to conclude. We've highlighted the differences, and I think future, we will need a lot more data for us to conclude. Thank you very much.
Thank you very much, Jamie, for this excellent talk. Michael?
Okay. Studies like these, they have a very comprehensive definition of what it means to be an Asian. Typically, there's a lot of activity in clinical research in Eastern Asia. So can you define more precisely which countries and ethnicities are in, whereas India, for instance, or Turkey, and the Iranians?
Yeah, so of course, if we have a huge study, it would be nice to go into more granularity. And this, as mentioned, from the Asian countries are from Singapore and Thailand. So it's mainly East Asian. But even within Singapore, we have also Malay and Indian.
Yeah.
And even from the U.S. population, this is Hawaii and U.S. So they also have some Asian patients amongst those. So, but by and large, we also did a sub-analysis looking at Asians patient within the non-Asian country. But those sub-analyses were done, but they didn't change the overall conclusion. But I agree with you totally that these are a huge generalization, but we can't really differentiate that with a sample size of 144.
We need more background knowledge to better serve our patients.
Yeah, and similarly with so-called and we call that non-Asian. We didn't say if there's European descent, among European descent, there's also so much heterogeneity. Point well taken. Thank you, Michael.
So, Jamie, just wondering, is it driven by genetics? Did you do genotyping? Is there a hint, first, second? Would anti-complement therapy still be an option in these populations?
I think I can just hypothesize at the moment. We certainly don't have enough data, but I believe, there is genotype differences in terms of the underlying background. But so far, with the current tests that we have, we found, in fact, more similarity between the Asian populations than differences. So maybe we need to look at perhaps even non-Mendelian type of genetics, and we're looking into, for example, interrogating mitochondrial DNA moving forward.
Thank you.
Thank you.
Thank you very much. And now it's completely my pleasure and honor to invite my co-moderator to hear from Mr. Geographic Atrophy in the world.
Thank you. You didn't say Mrs. in any case. But so in the last two talks, we address therapeutic options for dry AMD, and Arshad Khanani will go into wet AMD after the previous talks. And I think we have gone a long road, anti-VEGF therapy around more than 15 years, but nothing to offer to our patients. And this has changed now, obviously. In contrast to wet AMD, we see here this time-lapse movie. Geographic atrophy is relentless. It keeps on growing. It's not self-limiting. It doesn't form fibrosis and stubs if we don't treat it. It continues beyond the macula, so it's not a pure macular disease, if you will. And the beauty, and this is work by Steffen Schütz-Falkenberg, that we can objectively, precisely and robustly measure these expansion growth rates, which the regulator then jumped on it, accepting this as a primary anatomical endpoint to test efficacy of interventions, because BCVA, best corrected visual acuity, simply would not do. You know the phenomenon of foveal sparing, that the fovea seems to be more resilient and only later in the course of the disease is encroached by atrophy. So BCVA wouldn't do, and again, it's not a psychophysical measurement here, it's really robust imaging-based, also AI-based measurements. So three scenarios have to be distinguished. We want to slow progression. Ideally, we want to prevent late stages to happen. And if there is foveal involvement, we wish to improve. And I will allude to these three aspects in the few next minutes. Fortunately, it has evolved into an extremely dynamic field. There are so many mechanisms of actions considered, explored in a preclinical stage, in a clinical stage. So this is good news that in this multifactorial disease, we find something, maybe not a golden bullet like VEGF, but again, seeing other things that pop up that may modify the natural course of the disease. And of course, it was first now anti-C3 and anti-C5 who made the hurdle of a positive phase 3 result, which is, again, good news for our patients. So far, only approved in the US, and I know that Arshad and Steffen already have experience in treating patients. Here in Europe, it may be coming up next year, but it's good to already now think of perhaps patient selection. There are other anti-complement approaches by RNS tackling factor B and a small molecule anti-factor D molecule, which is an oral medication, no treatment by intravitreal injections, which have the advantage of less invasive and treating both eyes at the same time. And there's a number of gene therapy programs also tackling the complement system. Now you have seen also at this meeting at EURETINA these graphs. Here expansion rates are plotted and it's compared to sham, and we see treatment effect and effect sizes of here up to 22% with either monthly or 2 monthly injection into the eye, and the same, roughly the same plotting here of the GATHER trials with the other drug avancicaptad pegol as opposed to pegcetacoplan. And here also we get significant reduction in expansion size. And the good news for patients in the future will be that there may not be any more sham treatment arms for clinical trials, but that we can offer active treatment to any of the patients enrolled, and we lived through that with the first anti-VEGFs. Some of you may recall ANCHOR and MARINA when we compared against sham, and this was over after these seminal publications. Now, looking at mean progression rates could be potentially a little bit misleading. There's a huge inter-individual variability how these progression rates behave. This shown here with spaghetti plots of also anti-complement combined therapy by Novartis. And there may be also poor responders or non-responders that we need to identify if we do this treatment in our patients. To cut a long story short on the safety, which is of course of utmost interest if we inject new agents into the eye, and again, cutting a long story short, there is a trigger obviously for exudative for MNVs to grow at the border of geographic atrophy. We see this in the natural history, but the incidence is higher under anti-complement therapy, and the molecular mechanism is completely unknown. As of yet, there's just some speculation. But it means we have to monitor these patients regularly with OCT, and if something like this pops up, we may need combined treatment, anti-VEGF therapy, and anti-complement therapy for the two phenotypes. Inflammation is an issue. Just recently, 10 cases of retinal vasculitis reported post-marketing in the US with pegcetacoplan. Some of them went well and responded to steroid and immunosuppressive treatment. Some of them did not, and there are a few cases of ischemic optic neuropathy. Now, what patients should we be treating? Should we be selecting? You may know that the label in the US is very broad. You can use it for any geographic atrophy, and there is already now a thinking that we would look at subgroups that may benefit the most. Here is an example of a patient with lost fovea in both eyes, should be treated in such circumstances. Here, a patient where the fovea is still alive with good central optotype visual acuity, and perhaps the first patients that we may consider is where one eye is already down from atrophy in the fovea, and in the other eye we have preserved foveal tissue, and this lending to the concept, if we keep the fovea alive and happy longer, we can postpone loss of foveal retinal sensitivity, which would be enormously clinically meaningful to our patients, and they would be highly motivated to receive treatment because they have learned what happened in their other eye. Now, just 3 examples how AI could possibly help us in dealing with these patients in our clinical management. The Economist recently alluded to the opportunities with AI, but also the dangers, as we know, but I see 3 very positive opportunities that I will share in a second. One, monitoring. We can't look at OCT getting thicker or thinner as in anti-VEGF therapy. We need easy plotting of expansion rates over time. Ideally, we have software, and this is done here by the GA Grader software that retrieves your images from your imaging device, OCT-based, does automatic measurements of the lesion sizes, and then ideally, when you start treatment, you would see a deflection of the slope and thereby confirm that the patient is benefiting from this type of treatment. A second application was looking here, spearheaded by Maximilian Faur, that by AI-based automated measurements of lamina of the outer retina, of the photoreceptor layer here, outer nuclear layer, which shows a meltdown just outside atrophy. And this also led to the observation that the photoreceptors go down first in geographic atrophy, and then the RPE comes. That was the opposite view previously, but these studies demonstrate this is clearly the case. When you see this thinning, then over time atrophy will occur in these sites and can anti-complement therapy modify this? Yes, it can, and it has been measured with pegcetacoplan that outside atrophy, you slow this meltdown, which may open the door for treating earlier intermediate AMD, which is obviously the holy grail. And for AI application finally, and Steffen already alluded to that, it can be other diseases mimicking GA due to AMD, but for patient selection for anti-complement therapy, we must not apply this treatment in other etiologies because there's no proof for benefit whatsoever. Autofluorescence is helpful, OCT is helpful, of course genotyping may be needed, and there's a huge list, as a matter of fact, in collaboration with a Dutch group, Camille Boon and Carol Hoying, a huge list of masqueraders that we have to consider in order not to treat the wrong patient. And again, the third example of AI application, the I2 Gene project by Nicolas Pontikos, that will help us to, by the click of a button, AI, is it AMD or is it not AMD, which will be helpful in our very basic practices all over. Postponing treatment, we don't have validated endpoints yet for intermediate AMD. The MACUSTAR study here in Europe is trying to do this and accomplish this together with EMA and the regulatory authorities. And finally, of course, we need something to improve vision once we have lost the fovea, and just one glimpse at an approach with a photovoltaic bionic chip that is implanted that we did here as part of a study that then where you can recover function, and we are aware of gene therapy and also cell-based therapies, but this is early days, obviously, and until this will be available for the treatment in our patients. Thank you.
Thank you, Frank, for this amazing overview and talk. And of course, you're a leader in all the research and also in the clinical world. Can you just tell us how is now your approach to a GA patient that did not lose the center yet?
Well, at the moment, there's no approval for the anti-complement therapy here in Europe, so we have no really active treatment. We have heard from the NEI that there may be an impact of the ARET supplementation, but this is early days. We do not yet recommend it because we feel we need a prospective randomized trial if this is also an option to treat. So it's really watch and wait until the approval is there.
No, but let's say you have approval, just for the sake. Tomorrow, let's say there is EMA approval.
Yeah. Well, definitely, again, we will be learning, and the learnings from the US are pivotal here too, but I would start in the patient, one eye lost, the other eye preserved fovea to keep this fovea alive for a long
Monthly,
time.
bi-monthly?
That's a good question. In the US, I hear 80% are being treated bi-monthly, so it's a risk-benefit evaluation, but it's also patients above average age, above 80 years of age, so coming in every month, maybe for years, maybe for 10 years.
OCT every time the patient comes?
OCT every time to monitor for exudative manifestations and also plot our atrophy growth over time.
Stop ever or continue forever?
Yeah, exit criteria, nobody knows yet.
Thank you very much, amazing.
Great talk. So in the next 7 or 8 minutes, I'm going to be covering the emerging therapies for exudative AMD. Here are my disclosures. I'm involved in a lot of clinical trials, and everything I'm presenting today, I'm involved as a site, as well as on the advisory committee in most cases. So we have excellent treatments currently, and we are so lucky that we had approval of faricimab last year and recent approval of high-dose Eylea. The second generation agents are designed to provide better durability, and of course you're aware Port Delivery System was approved. It's currently voluntary recall, but should come back in clinical trials later this year. So as a field, we are moving towards better durability. And here I'm going to be talking about the emerging treatments that are in phase 2, phase 3 stages. So what are the 2 unmet needs in our space? Number 1 is better vision. So we have sozinibercept or OPT-302 that is looking at better visual outcomes than what we have achieved with VEGF-A inhibition. And the other one, the big unmet need, obviously the biggest one, we know the real world data shows that Frank, Rami, and Anand, they've shown that, in real world, we don't get the visual outcomes we see in clinical trials because of treatment burden. So we have to have better agents with better durability. And there are 2 classes of drugs that I'm really excited about. First one is TKIs or tyrosine kinase inhibitor. And we have multiple programs in development for that. And then gene therapy for common retinal diseases. It's not sci-fi, it's a reality, and I'll cover some of the programs that are looking at gene therapy for exudative AMD. In terms of OPT-302, it is a soluble VEGFR3 trap fusion protein. It's a potent inhibitor of VEGF-C and D, and the idea is that with chronic suppression of VEGF-A, you have elevated levels of VEGF-C and D, and if we block those, can we end up with better visual acuity? Well, this was studied in a large phase 2 trial, which actually showed superior visual gain at week 24 with sozinibercept or OPT-302 combination therapy with ranibizumab, and these were naive patients. But more interestingly, what we saw was there was actually better visual acuity gains in patients with occult-containing lesions, where we saw a benefit of 5.7 letter, 1 line of vision, which becomes clinically meaningful. This program is in large phase 3 studies. The 2 studies, SHORE and COAST studies, are looking at combination of sozinibercept with ranibizumab at different dosing regimen, and in the COAST study looking with aflibercept. These are large trials, one of the largest trials done in naive AMD patient population, 990 patients in each trial. These are ongoing, and we expect to see completion of these trials in the future. In terms of tyrosine kinase inhibitors, what do? They're pan-VEGF inhibitors. So idea is that you're blocking, pan-VEGF, and you're going to be able to hopefully have sustained disease control. There are multiple different tyrosine kinase inhibitors. These are all being placed in sustained delivery platforms, and some of these are actually approved for systemic diseases. So we have axitinib, which is being studied in 2 programs, OTX-TKI as well as CLS-AX, and you have the vorolanib, which is being studied in EYP-1901. One thing about tyrosine kinase, they also block PDGF because they're pan-retinal blockers. They actually block it intracellularly. So OTX-TKI implant, as you know, is delivered using intravitreal injection in clinic, is bioabsorbable, is targeted and sustained delivery. And the idea is that can we stabilize disease with this implant? It's very easy to administer. It's a 25-gauge needle. And what we have seen is we have seen 1-year data from the US study where patients receive either OTX-TKI versus aflibercept every 2 months. And what we noticed that OTX-TKI in previously treated patients maintained vision and CSFT comparable to aflibercept Q8 week, with a significant reduction of 89% in treatment burden by month 12, and 60% of patients did not require rescue up to 12 months. The safety has been good. Any new agent we look at, we are paying very close attention to safety. It has been well tolerated. The next step is the pivotal trial. The first pivotal trial for OTX-TKI will be initiated very soon. In terms of EYP-1901, this is also a sustained delivery. This is a different TKI, as I said, is vorolanib. And again, looking at previously treated patients with neovascular AMD. And the idea is that you're using a new mechanism of action, TKI, and you're also doing sustained delivery, combining those to have better durability for our patients. This was studied in the DAVIO phase 1 study. It was well tolerated. There were no drug-related SAEs reported. In terms of efficacy, we saw that 6 months median time to supplemental anti-VEGF therapy in previously treated patients, 35% were supplemental free at month 12, and 73% treatment reduction. The DAVIO 2 study is fully enrolled, and we expect data later this year. CLS-AX is actually also axitinib like OTX-TKI, but this is a suspension that's placed in the suprachoroidal space. As we know, FDA has approved steroid in suprachoroidal space. So the idea is, can we deliver in the suprachoroidal space to have more compartment delivery and target the high levels where they are needed? This was studied in the phase 1 studies. It was well tolerated. There were no drug-related toxicities or inflammation. And what we saw in the phase 1 OASIS study, that majority of the patients could go 6 months or longer. We also saw treatment burden reduction of about 72%. This is being evaluated in the phase 2 Odyssey study, which is currently ongoing. Now, let's talk about gene therapy a little bit. Gene therapy can be delivered in multiple different ways: intravitreal, subretinal, or suprachoroidal. ABBV-RGX-314 is a gene therapy vector that uses an AAV8 vector, and it takes the transgene for a protein similar to anti-VEGF fab like ranibizumab. This is being studied subretinally or suprachoroidally. We have seen the long-term data from the phase 1/2A study of RGX-314. We have seen long-term disease control. These patients are going to be followed for 5 years. The regulatory requirement in the US to follow gene therapy patients for 5 years. It's been well tolerated. We have not seen any drug-related inflammatory event. We have seen pigmentary changes in the areas of the bleb, and that's why we moved the bleb inferiorly in the pivotal trial. So actually, Atmosphere and Ascent are two phase 3 programs, and Ascent is actually a global study, so many sites will be activated outside the US. So hopefully in next few years, we'll know if gene therapy subretinally done in the OR will get approval. In terms of AAVIATE phase 2 study, this is the suprachoroidal study of RGX-314. We have seen efficacy. We continue to learn from this program in terms of efficacy by increasing the dose, as well as we have seen some inflammation and addition of prophylactic steroids have helped reduce that in this program. Intravitreal gene therapy is also exciting because, again, like suprachoroidal, you can deliver in clinic, so you can help a large number of patients. The most data we have is Ixo-vec or ADVM-022 program in the OPTIC study. This is a transgene for aflibercept. You inject this in the eye, your eye becomes a biofactory for aflibercept. And these heavily pre-treated patients in the OPTIC study, we saw excellent efficacy. There were 2 doses studied in this program, 6E11. The dose was lowered because we saw great efficacy to 2E11. And the treatment burden reduction was anywhere from 80 to 98%. What we learned was patients in the high dose had long-term inflammation, even though we did prophylaxis, but we didn't know what prophylaxis was needed. So that's why we continue to push the field to have better prophylaxis for gene therapy, intravitreal delivery. So now the LUNA study is looking extended topical as well as intravitreal and PO steroids. And the last one I have is 4D-150. This is also intravitreal gene therapy that's designed to be delivered in clinic. This is a dual transgene. Not only you have aflibercept, but you also have interference mRNA for VEGF-C. And you saw the data from OPT-302 that VEGF-C inhibition helped patient achieve better vision. So the idea is, can we have dual transgene and help our patients with neovascular AMD? This is studied in the PRISM study, which is a phase 1/2 study. The learnings from the OPTIC program was taken here. The dose is much lower than what was used, and the prophylaxis is a 20-week topical steroid. And because of that, I believe that we have seen excellent safety profile. The doses 6E9 to 3E10 have been well tolerated at 9 months, and 14 out of 15 patients didn't require any topical steroids past 20 weeks. So super exciting program with 81% reduction in anti-VEGF annualized treatment burden with stable BCVA and CST. So as a field, this is good news for our patients that we have a lot of different programs trying to push the field forward. And I want to thank again Frank and Anat for the invitation. Thank you.
Thank you, Arshad, for your brilliant talk. It's really amazing what's in the pipeline, and you described it extremely elegantly. I was wondering, so our armamentarium is growing. If this all comes to market, how would you personalize your approach, your management of wet AMD patients? How would you choose and pick and select?
I think that's a good question, and I think it's going to depend on the long-term efficacy and safety. We have great agents. So I think if I have a naive patient, I'll start treatment with the most potent anti-VEGF injectable and then stabilize the disease. And at the same time, we can introduce a tyrosine kinase inhibitor, which can stabilize. There will be patients who can go up to 1 year. There are patients who are high need. They may still need their injections. And in terms of gene therapy, we still have to see the long-term efficacy and safety. I think the subretinal program we know has great safety profile, but is obviously done in the OR. So that's the first step that is going to be for a subset of patients. But as we move towards suprachoroidal and intravitreal gene therapy, we may be able to modify, the disease. One thing I didn't talk about is for DR. We have suprachoroidal program with ABV-RGX-314 for DR, a disease that doesn't get treated until we have complications. And if you have a one-time gene therapy for that, that would be great too. So very, very exciting. But I think just like we do with any new treatment, we will learn and figure out what's the best for our patients.
Mm-hmm. Excellent. Andrew?
Thanks very much. For the suprachoroidal delivery, is there any concern of patients being on anticoagulants of risk of, suprachoroidal hemorrhage?
That's a really good question. So we have a large data set from the Clearsight suprachoroidal device that was used in the steroid trials that FDA has approved. So we didn't see any correlation. I actually asked for it, and we have not seen that in the gene therapy program. So it appears to be very safe. It's an easy procedure to do. I think after you do one or two of these, it's very quick, just like an intravitreal injection.
Thank you.
Excellent. Thank you so much. Thank
Thank
all
you
the
very
speakers of this session. And to Anat, on behalf of EURETINA, I wish to express our solidarity with Israel.